Good afternoon, members of the committee. My name is Jamie Reed, spelled Jamiereed. I am a Missouri resident, a lifelong Midwesterner, a lesbian, and a clinical researcher who spent nearly 5 years working inside of a pediatric gender center at St. Louis Children's Hospital. I am the region's whistleblower. I treated nearly 1,500 pediatric patients within a pediatric gender center. I am here because Nebraska's policies do not exist in isolation. When a state adopts different medical standards for children, we know that interstate medical travel follows. My home state of Missouri has concluded, after my whistleblow, to ban completely the use of puberty blockers, cross-sex hormones, and surgery for minors. Lawmakers reached that conclusion in part after reviewing internal clinical data and outcome information that I provided from inside this medical system. Kansas then reached the same conclusion after examining similar evidence. South Dakota and Iowa has also since enacted comparable protections for children. When one state maintains a looser standard than its neighbor, it becomes the place for those to travel for harmful interventions that the home states have determined are not medically justified for minors. This is placing Nebraska now in the position of impacting the healthcare policies of the rest of the Midwestern region. I also want to address why your earlier law included these so-called extreme case exceptions. At that time, policy was relying on two assumptions: that there was a distinct category of a true trans child, that this kind of child existed, for whom medical transition was necessary, and that withholding these interventions placed children at a uniquely high risk of suicide. Both of these assumptions have now since been undermined by long-term better data. Long-term follow-up has not confirmed a discrete diagnosticable category of child who benefits from a medical transition, and in the recent Supreme Court argument, the United States v. Scarametti, even the ACLU acknowledged that claims of inevitable suicide risk are not supported by reliable evidence. Other states had similar laws and loopholes like you have, like West Virginia. I traveled to West Virginia and testified. They have now removed that loophole. There's another reason why this matters. Children are more likely to identify under this true trans model are those with long-standing gender nonconformity. Decades of developmental research shows that most of those children, if left alone, would grow up to be gay or lesbian. I now run an organization that exists to protect these children for what we consider a new kind of conversion practice, one that teaches children their bodies are wrong rather than allowing them to grow into healthy gay or lesbian adults. I would like to conclude by saying, Senator Harding, I can answer your questions regarding puberty blockers and the questions regarding profit and the cascade effects. Senator Reppy, I can answer the cross-sex hormone question if it requires that hormones are medically necessary for the future, and also the questions regarding suicide risk. Senator Quick, I can answer your question regarding puberty blockers when it's used in precocious puberty versus used in trans care. And Senator Meyer, I can also discuss suicidal ideations, whether or not they're coming from the patient. Thank you.
I saw you earlier. You kind of looked like Horseshack on Welcome Back, Kotter, because you were over there going, ooh.
I can answer all of these questions.
To those. Welcome that. So, sure, start with mine, because I like my question the best.
Perfect. So your first question regarded the use of telehealth for a puberty blocker.
Yes.
That is an inappropriate use of telehealth because in order to determine if a puberty blocker is necessary, the first thing in this model of care is to determine what Tanner stage the patient is in. There are 5 Tanner stages. The model of care said you should start this at Tanner stage 2. In order for a clinician to decide or determine if a child is in Tanner stage 2, they actually have to do a physical exam. They have to examine the breast tissue development, and in boys, they actually have to determine the testicular size. They have to physically examine a child in order to properly determine if the puberty blocker is time if you're following the model of care. In addition, the way that puberty blockers are actually given are either an implant in the arm, so this is a same-day surgical procedure, so you can't do something like that through telehealth to actually implant the device, or it's given as an injectable. That injectable is so expensive that it is not even worth the risk for most clinics to let that injectable go home with the patient. The single injectable is about $60,000 in Missouri terms. And we would not even give that. It could be given at home, but it costs so much for that single use shot we would not even send it home with a patient. It's just too much cost-wise.
It would be irresponsible.
Correct.
Okay. And then, let's see, you had a list of others, and I'm willing for them to have their questions answered too. So anyway, you mentioned Senator Reapy. You had something for him?
Yes, you had asked the question if cross-sex hormones creates a requirement that that hormone is medically necessary in the future. There's only one instance in trans care where that becomes true. If somebody has their gonads removed surgically, so if we have a male go through what is referred to as bottom surgery and we remove surgically their gonads, in order for their long-term health, they require some kind of sex hormone. Usually, if we're in a trans patient, it would be an estrogen derivative. There's no reason why they could not go back onto testosterone, but because we have physically removed their gonads, they cannot produce sex hormone anymore. That's the only instance where somebody medically needs to remain on any type of cross-sex hormones. Since there's no surgical procedures allowed in this state in minors, there's absolutely no medical reason why somebody once put on a cross-sex hormone has to remain on it. We can easily take them off. One slight example of this is we had patients who would travel to go on vacation. Say they go to Florida. We had put them on testosterone at 13. Now they're 16. They forgot their medicine at home. They would call thinking it's an emergency. Oh my gosh, I have to have my shot. The endocrinologist was like, this doesn't matter at all. You can stop these drugs at any time with zero medical complication in stopping it. There should be no concern in the state about stopping a minor who had been put on these interventions. The only risk or concern is once you have post-surgical gonad removal. That's the only time there's a medical risk.
Okay, thank you.
I had also asked about what's the best possible outcome physiologically that could happen if someone were to get on the hormones. What's the best thing that we're hoping for that can happen anatomically for someone when they're saying, I want to, cross the hormone bridge? What's the best possible medical outcome?
A purely cosmetic result.
Okay,
There's nothing else to it besides cosmetic.
very well. Other questions? Senator Hanson.
I had a couple questions. I think maybe you can raise your hand on them.
Yes.
And I think you touched on one of them. But first, I asked a question. You mentioned your background a little bit, or kind of where you worked. Can you explain that just a little more? 'Cause I'm
Yes.
curious about that. 'Cause you have a unique testimony, I think, that maybe lends itself some credibility to what you're saying. So I'm kind of curious about the
Correct.
background part.
St. Louis Children's Hospital opened a pediatric gender center in 2017. I started working there in 2018 as the social worker and the clinical research coordinator. My background, I have a master's of science in clinical research management. I was hired in 2018 and I worked on the multidisciplinary team in that center, and I assisted on that team in medically transitioning almost 1,500 unique patients. We medically transitioned 80% of the kids that we saw. St. Louis Children's Hospital opened that center in 2017. It was completely closed by 2023 because I blew the whistle. Because I came out as a public whistleblower, I went to the Missouri Attorney General's office with troves of data, troves of research, and I showed Missouri Senate and the legislature that this intervention not only was based on shoddy research to begin with, but that we were significantly harming our patients. And I became a whistleblower out of that industry, so that hospital center has now been completely closed. Missouri has stopped all of their pediatric gender centers.
Okay, I think that might get to the heart of my question about bias. So is it reasonable to say that when you first started there, you maybe had, I would say, a bias maybe towards some of these treatments, or because of a lack of what you saw or lack of knowledge, you're like, this sounds good, these kids need help, how can we help them, that kind of stuff. But then over the course of time, your bias kind of started to change, or your level of thinking about this subject changed because of what you saw. That'd probably be correct, wouldn't it?
Absolutely. So when I started working in the center, I would be what you would refer to as a true believer. I not only believed that such a thing as a trans child existed, but I believed that the earlier we could intervene, the better in the long-term outcome. This is kind of what we talk about in autism services or other services with kids. If we start an intervention early, perhaps we'll make it better for their life. It wasn't necessarily that my bias changed. I'm still from the community. I'm still a lesbian. I was married to a trans-identified adult at the time. What changed was the actual evidence in front of me. So what I started to see, first of all, is that these patients were not getting better. So their mental health was not improving, although that's what's promised in the intervention, that their mental health will get better. It wasn't happening. But also what we saw, which we've seen internationally, is there has been a complete absolute social contagion element that just tore through this industry. When I started in 2018, we had 4 new patients per month, and they were almost all pre-pubertal boys who acted very feminine. When I left, we had 60 new patients per month, and almost every single one of them was a trans-identified adolescent girl who had multiple mental health comorbidities, who had been sucked into trans as an identity, who had been sucked into it from social media, from their COVID lockdowns, from their school. This completely tore through this industry in an unprecedented way. The reason why we talk about this at all is because there was one of the largest social contagions to ever happen in adolescent girls rip through this country over this. It's starting to wane a little bit, but the fallout is that we still have states that have kids who are still sucked into this contagion who are being medically harmed. But what I also came to understand is that there is no true trans kid. The little boys, those 4 little boys, when I first started that I thought, oh, they must be trans, what I've come to realize is those were little boys who most likely would grow up to be gay if we simply left them alone, or if we simply gave them supports, or if we simply didn't let them get beat up in the bathroom and be bullied. They probably would just grow up to be gays or lesbians like I am.
Yeah, I'm gonna ask me another question if I can. 'Cause I'm trying, with my level of questioning, not just with you, but others, and these are topics I think we run into all the time here on the HHS committee, is the idea of who can prescribe what can they prescribe and how. Okay, we talk about psychologists versus psychiatrists, and who can prescribe and who can't. And so, but I think we've always kind of tried to maintain a level of objectivity when it comes to a lot of that stuff, and that's what I'm trying to maintain. This is where some of the questions are coming from. Mm-hmm. It's not like the subjective opinions of others don't matter. Sure. But with the objective approach with this bill, it's like who can prescribe, who can't, and what. And so, I think you talked about systematic reviews, I think, in the kind of studies before. Can you explain that a little bit further, maybe, like, and why does that matter? Because when you leave here and the people in support of this bill leave, we're gonna have the opposition come in, and we're gonna have medical professionals come in here as well, and they're gonna cite other kinds of studies.
Correct.
And this is maybe where I haven't read them, and so I don't know, like, their kind of quality of evidence. Mm-hmm. And I didn't know, you kind of mentioned that, I don't know if you could touch on that a little bit, what that means, especially for the people who come in here and testify in opposition to this.
Yes, so systematic reviews of evidence are at the very top of a triangle. So if you think about what kind of research studies are done, there will be thousands of research studies down here at this low level. That means that I could have a study with 10 patients, or I could have a study with 100. When you talk about what a systematic review of evidence is essentially, it is a ranking system where it takes every single paper that's ever been written on this topic. And then first thing it does is it ranks. Is this a quality study? Was it laid out correctly? Is there inherent bias in it? Was there a large enough sample size? Did it last long enough? Was it longitudinal or short? It reviews every single aspect of that, and it ranks the studies. And it says, of every single study that's ever been done about trans kids, these are the quality studies, these are the poor studies. Then it reviews the quality studies, and it basically gives a ranking. When we say something has low to no quality evidence behind it, it basically means, if you go back to the bare basics of what science evidence is I have a hypothesis, I want to test it. Did the study test the hypothesis and prove one way or the other the outcome of the hypothesis? 17 systematic reviews of evidence have been done globally. These are huge projects. Every single one of those 17 systematic reviews of evidence has come to the unequivocal conclusion that there is no quality evidence to support the medical transition of a child, period. Those were reviews that the country of Finland did, that the country of Sweden did, that Norway did, that the UK did. We're not talking about one person at a hospital writing a paper. We are talking about entire nations reviewed all of the evidence you could find, and there is not a single paper of systematic review that supports doing this. They do have a ton of low-level, low-quality papers that say, I gave this to 5 kids, oh, when I checked in on them 3 months later, they look better. That's not a quality, robust study. I want to add one little caveat to this too, from a question you had asked earlier about drug studies. Every single drug that is being used in pediatric gender transitions is being used off-label, which means no single drug company has ever put forward these drugs to say, I really like this. I think this is a good drug. I want to test it for this reason. Not a single drug company has ever done this. No puberty blocker has ever been tested to be used this way. No cross-sex hormone has ever been tested to be used this way. They don't support that, so everything is being used off-label, which means doctors have the ability to basically pick and choose whatever drugs they want without any evidence. We give doctors that ability, but no doctor can say that they are doing these procedures with these drugs based on a clinical drug trial. It's never occurred.
No, along those lines, if I can ask again, sorry. And if you don't know this, it's okay. Are these pharmaceutical companies, if they find out that these puberty blocking hormones used for this purpose found out to be detrimental, are they liable?
No, they were never FDA approved for use. The drug company never went to the FDA and said, I want to test this puberty blocker for this reason. The drug company that created it never put it forward to the FDA for that use. They're all off-label. They're all outside of that normative FDA approval process.
Okay, which is odd, okay.
It is odd, but it's also dangerous and scary when you think about that we are using all of these drugs completely outside of our normative FDA approval process, or in any way, shape, or form in a clinical drug testing regimen that we would use for any other drug, and we're using them on children.
Can I ask one more? Sorry.
Certainly.
Because this touches on this touches on the first thing that you said about the quality of evidence.
Mm-hmm.
So we're gonna have people come in here in opposition to this, medical professionals saying, I have treated children and I have seen outstanding results, and those studies don't matter because this is what I see, right? So how, in light of what we're gonna hear, which I'm assuming, and they may be legitimate, they may what they see or what they think they see, whatever. In light of that kind of testimony that we're gonna hear, and you're saying all these studies are low quality, like how do you justify like what they're gonna say or?
Yeah, that's a very common occurrence, and that is not something that surprises me at all. So one of the ways that I think about this with the endocrinologist that I worked with, who was medically transitioning kids, we had Tuesday clinic, we saw a whole group of patients. Which patients did he remember a week out? Was it the patient who came in, didn't really say much, left, and then fell off his schedule and he never saw again? Or was it the one patient out of 32 who brought him, and I kid you not, flowers, candies, and a photo album showing, oh my gosh, look at this amazing transition you walked me through? That's the patient Dr. Lewis remembered, a month out, 2 months out. That is not data. I am a clinical researcher. I cannot care about the line item patient because they brought me flowers. I have to care about what does the system of data tell me. And in that, what it told me in my clinic is we lost 30% of the kids that came in and we put them on a treatment, they disappeared. And they didn't disappear because they moved or went to college and they were happy. They literally disappeared out of my Epic trans care. They were still in St. Louis. They were still seeing their pediatrician. They were still right there. We put them on something that they then determined was hurting them or they didn't want to do anymore, and they disappeared. My clinicians have no recollection. They weren't looking at the data set. They're never going to remember, oh, that kid I saw once that I put on testosterone, I permanently destroyed her voice. I never saw her again. I don't remember her. That's how it works when you are a clinician. They're not wrong. They are going to say that there were patients who feel like this made them better. But adolescents, when given what they want, will tell you, it made me feel better in the short term. That doesn't make it safe and efficacious in the long term or across the whole data set.
Thank you.
Senator Ballard.
Thank you, Jerry. Thank you for being here. I do have one question. Senator Kauth brought up something interesting about pediatric gender clinics and their assessments. Can you talk, in your experience, can you talk a little bit about that assessment process? What does it entail? How does it interplay with studies? Just a little bit about your experience in gender clinics.
Yes, that's an excellent question. When this protocol was first devised in the Netherlands, they had this very long, very intensive, what they called a biopsychosocial assessment. It would last sometimes for years, and it would cover all of these aspects of the individual's life and often would include intensive psychotherapy. That model of care jumped to the US. It started here in Boston at the First Gender Center in 2007. Immediately, they realized they did not have the bandwidth, the time. We charge things differently. We don't have a nationalized healthcare system. They didn't have a way to replicate that biopsychosocial assessment. What has happened since 2007 until now is that assessment has whittled itself down to the point where in my clinic, we would medicalize a child after a single visit with a psychologist, one 1-hour visit, and the assessment process was that they were required to write a letter of support to say, I met with this child, they meet criteria, you can medicalize them. We wrote the letter as a blank template. We handed it to the psychologists and said, hey, after you see this patient for an hour, just fill this out. We only wrote one template. We didn't write a letter that said, I met with this patient, they don't meet criteria, or I met with this patient, they need more time. The only letter that we gave the mental health professionals was, I met with this patient, put them on a medical treatment pathway. The industry has become directly where essentially we've heard doctors say, if a child says they're trans and wants this treatment, that is the full breadth of the assessment. And I'll add, I met with 3 psychologists from within your state about a week ago. I tried to ask them, what is your assessment process? Are you doing something different to figure out if these are extreme cases versus not? They directly said, trans children tell us who they are. That was what they described as their assessment process. Your psychologist in this state still going through the loophole.
Thank you.
Any other questions? Thank you